Picture this. A patient walks into your clinic, you prescribe a standard, run-of-the-mill medication to help them out. But lurking quietly in their chart is another perfectly common drug. What happens when those two meet? Well, it can trigger a catastrophic, sometimes even fatal reaction. We are navigating a clinical minefield every single day, and honestly, missing the wrong combination can quite literally cost lives. Welcome to The Explainer. Today, we're tackling a true clinical survival guide, drug interactions you simply cannot afford to miss. Now, retaining this kind of high-stakes medical data can be really tough when it's buried in endless, dry textbook paragraphs. To make sure this information actually sticks when it counts, we wanted to generate this video in detail in an engaging and attractive way, basically carving this vital pharmacological info right into your memory. Our roadmap today comes straight from the brilliant minds over at MedicoInfo1, specifically their incredibly thorough Drug Interactions Don't Miss cheat sheet. The original document is fantastic, but it's dense. So we're transforming it into a structured, highly visual guide, breaking it down piece by piece so the absolute most critical takeaways pop out at you. Okay, let's dive into this. Here is our visual roadmap. 1. The CNS danger zone. 2. Endocrine system pitfalls. 3. Treating infections safely. 4. Blood thinners and DMARDs. And 5. Crucial rule updates.
Section 1. The CNS danger zone, focusing on psychotropic drug risks.
So the central nervous system is notoriously sensitive, right? Common SSRIs and lithium can become incredibly hazardous when you pair them with seemingly harmless everyday drugs. For example, mix an SSRI with tramadol, a triptan, or an MAOI, and boom, you've opened the door to serotonin syndrome. Combine that same SSRI with a basic NSAID or an anticoagulant, you're risking a GI bleed. And for your patients on lithium, adding an NSAID, an ACE inhibitor, or a thiazide diuretic is practically a one-way ticket to lithium toxicity. The stakes get even higher with anti-epileptics. Let's say you have a patient on carbamazepine or phenytoin, and you introduce inducers, like rifampicin. You're going to see severely reduced drug levels, which could easily trigger a breakthrough seizure. But the combination that should literally make sirens go off in your head? Valproate paired with lamotrigine. This dramatically escalates the risk of Stevens-Johnson syndrome and severe rashes. It's a pairing that requires extreme caution, for sure. Moving right along to Section 2, endocrine system pitfalls and metabolic control risks. For your diabetic and thyroid patients, steady metabolic control is the whole ballgame. Now, a classic interaction we all learned is metformin combined with IV contrast, which historically carries the dreaded risk of lactic acidosis. Keep that one in the back of your mind, though, because we actually have a major update on that rule coming at the end of the explainer. Moving down, if your patient is on sulfonylureas, combining that with alcohol or a beta blocker leads to masked hypoglycemia. That's terrifying because the patient literally loses their natural warning signs of low blood sugar. And no surprise here, pairing corticosteroids with NSAIDs is a fast track to a GI ulcer or bleed. And this brilliantly illustrates how even over-the-counter additions can totally wreck a treatment plan. Take levothyroxine. If your patient takes it alongside simple, everyday supplements like calcium or iron or just a standard PPI, it significantly reduces the absorption of the thyroid hormone. The treatment basically stops working. Also, keep an eye on SGLT2 inhibitors. Combine those with diuretics, and you're looking at severe volume depletion or even euglycemic diabetic ketoacidosis.
All right, Section 3, treating infections safely, with a spotlight on antibiotic interactions.
We usually think of antibiotics as the good guys, don't we? But they can trigger some of the most hidden, dangerous interactions out there. I want to test your clinical reflexes for a second. What is the exact consequence of mixing macrolide antibiotics or quinolones with other QT-prolonging drugs? Take a quick second to think about it. The answer? Torsades de points and cardiac arrest. This is a massive point of clarification from the MedicoInfo1 update. You have to remember that the consequence here is a lethal cardiac event, not just a mild GI upset. This is an absolute stop everything, red alert interaction. Just to make sure we're completely grasping the severity of this villain team-up, let's define it clearly. Torsades de points is a specific, highly lethal type of abnormal heart rhythm. It can lead directly to sudden cardiac arrest, and it's very often triggered by those prolonged QT intervals. You absolutely do not want to be the one who prescribes a macrolide that pushes a patient's QT interval over the edge. Aside from the heart, antibiotics cause plenty of other chaos. Mixing macrolides with statins, like simvastatin, can cause severe myopathy or rhabdo. Mix trimethoprim with methotrexate, and the consequence is pancytopenia, a total, devastating wipeout of blood cells. Then there's the classic weekend ruiner, metronidazole and alcohol. If your patient has a drink while on this antibiotic, they're going to suffer a severe vomiting-inducing disulfiram reaction. And finally, rifampicin is a notorious inducer. Combine it with the oral contraceptive pill or warfarin, and you're drastically reducing the effect of those crucial medications. Section 4. Blood thinners and DMARDs. These are your high-stakes combos. If the previous sections were about dodging potholes, this section is about not driving off a cliff. Let's zero in on warfarin. You need to memorize the Fab 4 drugs: fluconazole, amiodarone, Bactrim, and metronidazole. Add any of these to a patient on warfarin, and their INR is going to dangerously spike, leading to a massive bleeding risk. And here's a sneaky one. Even oral miconazole gel can spike that INR. Further down, mixing clopidogrel with omeprazole actually reduces the antiplatelet effect, increasing clotting risks. Same goes for DOACs. Pair them with carbamazepine or rifampicin, and their effect drops, again leading to dangerous clotting. Switching gears to DMARDs, methotrexate combined with NSAIDs or PPIs can lead to severe MTX toxicity. Got a gout patient on allopurinol? If you add azathioprine, that convo results in severe bone marrow toxicity. But the absolute golden rule to remember here, prescribing live vaccines to a patient on biologics is a guaranteed ticket to a serious, completely preventable infection because their immune system just cannot handle the live strain. Finally, Section 5, Crucial Rule Updates. It's time to bust some old medical dogmas. Medicine is always evolving, What we were taught years ago might be completely revised today. Now, what's really interesting about this update is the metformin rule. The old dogma was that you must always stop metformin when a patient gets IV contrast to prevent lactic acidosis. The new reality? Metformin is actually no longer routinely withheld for IV contrast unless the patient's eGFR is less than 30 or they have a high baseline risk for acute kidney injury. That blanket rule is officially a thing of the past. Let's walk through a few more nuanced corrections. For edoxaban taken with CYP or PGP inhibitors, automatic dose reduction is out. It's now only needed in specific cases. For methotrexate and PPIs, the fear of MTX toxicity is actually quite low at standard doses. It's mostly a concern during high-dose chemotherapy. But okay, this last one is wild: theophylline and smoking cessation. It sounds completely backwards, but the clarification is that stopping smoking actually increases theophylline levels and leads to toxicity. The smoke itself induces the drug's metabolism, so when they quit, metabolism slows down and the drug builds up to toxic levels. It's a brilliant, counterintuitive pearl to remember. Okay, let's bring the whole shebang together. If you take away absolutely nothing else from this visual guide, memorize this rapid-fire recap of the worst offenders. 1. The triple whammy of an ACE inhibitor or ARB plus an NSAID plus a diuretic equals acute kidney injury. 2. Warfarin plus the Fab 4 or miconazole gel equals a major bleed. 3. Digoxin plus amiodarone equals digoxin toxicity. 4. Non-dihydropyridine calcium channel blockers like verapamil plus a beta blocker equals severe bradycardia or heart block. And 5. Cyclosporin mixed with grapefruit or azoles equals serious nephrotoxicity. These are the absolute deadliest combinations every clinician must know by heart. So, what does this all mean for us? Knowing just how hazardous this clinical minefield truly is, are you double-checking every single prescription every single time before it reaches the patient? A few extra seconds reviewing these rules could literally be the difference between a routine visit and a fatal outcome. Thank you so much for joining me for this explainer. I really hope this structured look at the MedicoInfo1 sheet has sharpened your clinical instincts. Stay vigilant, keep learning, and I'll catch you in the next one.